Welcome back to another episode of Single Payer Radio. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare. We are an affiliate of the Kentucky chapter of Physicians for a National Health Program, and we're proud to be a community partner with Forward Radio WFMP LP 106.5. Please join the Forward Radio family as a financial contributor or a volunteer. We're an all-volunteer radio station. You can go to forwardradio.org. Join us. And let me say the views and opinions expressed here on Single Payer Radio are those of the speakers and not the station. And real quickly, let me share with you a hospital bill that my sister shared with me this past weekend. It's a bill for 4 days inpatient care at St. Mary and Elizabeth Hospital that was located down on 12th Street at the time. Okay, here we go, folks. This is January 1954. 4 days for hospital care. She was only in the hospital once, and she was there for angina. But 4 days of hospital care, it was $11.50 per day. So that was $46. There was a lab fee for those 4 days of $5. Pharmacy and drugs, $5.45. X-ray, $10, oxygen, $11, electrocardiogram, $12.50. A 4-day hospital stay was $89.95. This bill looks like something I would get at Oscar's hardware store when I go down there. So how times have changed.
You can say that again.
Okay, so joining us back in the studio, as they have been since early spring, are doctors Eugene Shively and Michael Flynn. And I'm going to turn it over to the doctors right now.
Okay, I'm a retired general surgeon from Campbellsville, Kentucky, and I want to say that everything I say is that of my own. I don't represent Taylor Regional Hospital in Campbellsville, nor the Department of Surgery at the University of Louisville. A purpose of this program is for education, and right now things are changing so rapidly that things may be different from one day to the next. So we don't try to say that everything that we say is a fact, and it could change. And we try to have good news, not fake news.
Yeah, and this is Michael Flynn. I'm a retired surgical oncologist. I was on the faculty at the University of Louisville for 30 years and currently an emeritus professor. And as a disclaimer, I would also like to indicate that any views expressed here by me are my personal views and do not represent the views of either the Department of Surgery or the University of Louisville. So, Dr. Krause, let me, aside from thanking you for being here, I really don't know very much about the German healthcare system. So I was wondering if maybe as an opening statement or setting the table, if you like, you could give us a kind of a little historical background of, how the current system got started, whatever changes may have occurred from whenever it was at the beginning of that system. I mean, we know the National Health Service in Britain started in 1946, I think. So, and just to give us an idea of, because I have very little knowledge of the details of the healthcare system in Germany.
Sure. So I would say that that started back about 100 years ago. I would say in the early 20th century, even before the First World War, where Germany started to have some kind of a social healthcare system. And that has evolved since then. And currently, to give you a little bit of an overview, we do have socialized healthcare, where we basically, everybody has a basic health insurance that is paid for partially by the employer and partially by the employee. And then there is the option to have additional private insurance if you meet certain requirements. Only a small amount of people use that because the basic health insurance is very comprehensive.
Now, the funding, I'm assuming that is that general taxation, or in this country, there's sort of employers may have some part of the payment, the individual employee or the patient. So there's a number of different ways that money goes into the system. So how does that? What's the funding background of the German system?
So the funding background is that for the basic health insurance, the employer and employee both pay 50% off it, and that goes into it comes out of their tax returns, basically their wages, and that goes into big funds, and then the basic health insurance companies use that, and it gets distributed between those. There's not a big difference between the different basic healthcare insurances companies because everything is regulated on a national level. So regardless of which of the basic health insurance companies you use, it is still the same amount of cost that you would pay for certain services. And so that's how things go into the fund and how they are taken out of the fund. If a person has no health insurance whatsoever because they are unemployed or they're retired, then the state pays for it.
What percentage of patients are in that situation where they're totally unemployed or destitute and the state has to pay for their services?
Well, I don't have an exact number, but I would say that's maybe 5-10% max. I mean, it's a small amount, and that number can change. I mean, as soon as people get employed, then they would be off that list and they would contribute to the funds.
Now, the way I understand what you just said is that the national government negotiates or works with health insurance companies. Is that correct? To provide that health, the components of healthcare to the citizens. Is that a fair statement?
It is, but it is the same for each of the healthcare insurance companies for the state-based ones. So okay. They all pay the same, and so sometimes people, they switch easily between one or the other if they have to, but it doesn't really make a big difference because they all pay the same amount.
Okay, 2 follow-up questions. Number one, as you know, we have Medicare and Medicaid in this country, which are government-run health insurance programs, and we have a whole bunch of for-profit health insurance companies that provide health insurance in an assortment of different ways. Some of them are directly paid by the individual, some are paid by the company, and even some negotiate with the government. Is there a sort of an equivalent to Medicare and Medicaid in the German system? That's the one question. The second question then is, are these insurance companies that the government negotiates with, are they not for profit or for profit, or what's their status?
So to answer your first question, there is no direct equivalent to Medicare, Medicaid. It is the basic health insurance that everybody has, regardless of their age, regardless of, their status, if they're pregnant or not. And so I guess you could kind of compare maybe the German basic health insurances to the Medicare and Medicaid system, but that's like throughout the entire lifespan of a person. And then you have the for-profit insurance companies, which an individual can only add into, like, take on their services if they make above a certain amount of income a year. So the state does not want people to spend more than necessary cost on healthcare if they don't want to and can't afford it. So currently it's about 88 to 89% of all German citizens are insured through the basic health insurance companies, and the other 11 to 12% have additional these private insurances, the for-profit. And what the for-profit insurances give you is basically that you get a single room at the hospital if you're admitted. You get to see a professor or a certain doctor in the system. So those are kind of the advantages of having the additional health insurance. But to be honest with you, most people do not need it because the basic health insurance is very good.
Why would someone select a private insurance?
Well, in case that they want to see a specific physician. So there are some physicians that are contracted with the private health insurance companies, and others are not. So if they want to see one doctor, they would potentially pay that extra amount. If they want faster service, if they want to have a single, private room in the hospital after surgery, that's why they would pay it for. But otherwise, there's really not any good reasons for it.
Let me ask you another question on economics. One of the things that I've learned from Gene as we went through this, go through these series of programs, is that there's about $4 or $5 trillion in this country is revenue that is in the healthcare system, but about a third of that is not used to provide healthcare. It ends up going into executives' pockets. It is used for advertising, a whole series of other things, the pharmaceutical industry. Do you have a sense of how much of the revenue that's in the German system is actually used to provide health care as opposed to being siphoned off for some other purpose, like an executive's outrageous compensation?
I don't think I have a specific amount for you, but I would say that is definitively less than what it is in the U.S. because there's no, for example, advertising for drugs is not allowed. That's maybe something we can talk about later. And so you have a lot less money to spend on these non-directly medically related issues.
Do you think not advertising for drugs affects outcomes and affects the ability of the patient to get certain drugs in Germany?
No. So patients will get the drugs that they need to improve their condition. So I think it does not negatively affect the healthcare at all. It does affect, patients kind of coming to their doctors and telling them that they want to use this specific drug because they've heard that it works better for them. So that definitively is a big difference here compared to Germany. I mean, when I first moved to the U.S., I was like, I couldn't believe all the, drug advertisements that are on TV here. So that was something completely new for me.
Now, back to the kind of economic issues again. One of the things that we've learned as we kind of get into all these issues related to healthcare in this country is that between the mid-1970s and the mid-2010s, the number of administrators in this country compared to physicians exploded almost 3,000%, to the extent that today there are 10 administrators to every practicing physician, which is probably where a lot of that $1 trillion of money that's not being used for healthcare it goes. So I guess my next question is, how do you have any sense of the relationship between the number of physicians or practicing physicians in the German system compared to the number of bean counters, bureaucrats, administrators, managers, or whatever you want to call these people?
I would say it's a lot less than what it is in the US. I don't have an exact number because that's just not as big of a deal in Germany. I guess it's important to define what exactly is meant by administrators, but there is a lot less of that in Germany. It's the insurance companies, it is the physicians. We have, nurses who help. We have the support staff in the offices, but besides that, there's really no additional administrators. There's no nurse practitioners, APRNs, LPNs in Germany either. I don't know if you would consider those, along with administrators, but we don't have any of those in Germany.
Yeah, no, I consider those healthcare professionals. I'm talking about the bean counters, the guys with the suits that sit behind the computers, jerking them off and diverting money all over the place except for the use of healthcare. Do you have
if a patient comes to see you in Germany and you make a diagnosis and order certain tests, do you have to get pre-authorization and go all through the rigmarole that we'd have to in this country, or can you just call the insurance company and they approve it and you have it done and then they reimburse you?
So it's the latter. So everything, it does not have to be approved unless it is something very specific or unusual for the general basic health insurance. The private health insurances, they are a little trickier sometimes, to where you have to get a pre-authorization, or they don't want to cover it, or they want a letter from the physician stating that this is medically necessary. But otherwise, no. Anything that you order is usually paid for, and it's paid for at a specific rate. So the rate does not differ to which hospital you have the service done, which physician you see, or which insurance company you work with.
Many primary care physicians, including OBGYN, claim that they have to spend several hours doing paperwork in the United States, filling out electronic medical records. Do German physicians have to spend that much time doing paperwork and filling out electronic medical records?
Well, the time that they're spending on these things is increasing, but it is nowhere near where it is in the U.S. currently. I think a big reason for that is that there's less malpractice lawsuits in Germany in general. And so therefore, people don't have to jump through all those hoops to make sure that everything has been documented. They basically take it for granted that they have talked to the patient about it. The patient understands it, and that's all there needs to be done. So there's less time that they spend, but the time is increasing as well overall.
Why?
Go ahead, Jane.
Why do you think there are less malpractice suits and problems like that in the United States compared to Europe, and particularly Germany?
I think there's less, malpractice suits in Germany for one reason. Patients trust their physicians more. They do not seek second opinions as much as people seek them here. And there are the malpractice like lawyers, that does not really exist in Germany. So it's just a much more positive way of thinking in regards to the interaction between patients and physicians.
Now, if a patient does get harmed in Germany, for example, they had a hysterectomy and they had a complication, the German healthcare system continues to pay for that, and if there were a lawsuit, it would be paid for something unusual. Is that correct?
Correct. I mean, it's very rare to have lawsuits in Germany. The first time I really heard about that was when I moved to the U.S. And certainly if something, wrong gets done, then that will be investigated, and the healthcare system would continue to pay for any consequences of that.
Let's move off to a little different little aspect of this. One of the major causes of bankruptcy in this country is our medical. People being unable to pay their medical bills. We have about 40 million people who are uninsured and another 40 million people who are underinsured. And these people are all vulnerable to medical bankruptcy. And depending upon the year and whatever reference source you're looking at, we could have anywhere from 200 to 500,000 or 600,000 medical bankruptcies in this country on an annual basis. I read an article, a few months ago. I was putting a talk together. They indicated in 2017, a country of France that has 70 million people had no medical-related bankruptcies in 2017. So, and the question is, how much of an issue is that in Germany with your current system?
It is not an issue at all. The first time that I heard of medically related bankruptcies was when I moved to the U.S. So that is something that does not exist in Germany, again, because everybody has that basic health insurance, even if they are unemployed. And certainly, the Germans, but I think in case of a medical emergency, everybody gets treated properly without having to fear bankruptcy. So that's a big difference.
Dr. Krause, can you review the services that are covered under the German healthcare system?
I would say that pretty much everything is covered. Any, preventative services, the Germans are very, they focus a lot on preventative health care to decrease chronic conditions and their sequelae. And so everything is covered. If somebody needs surgery, that is covered. Some things, if the private insurance companies are starting to be less covered, for example, if you go to rehab after a big surgery, they used to cover maybe 12 weeks. Now they only cover 8 weeks. If you want specific equipment for your home to be able to move around after an accident, that sometimes is a little tricky to get, but otherwise, really everything is covered.
Well, suppose I wanted to go to a plastic surgeon and have a facelift so I could get rid of all the wrinkles on my face. Is that covered by the German system?
That is not covered. That is not covered. So that would not be considered medically necessary. But like, for example, plastic surgeons for burn injuries, that would be covered.
Okay.
Mental health services, maternity services, long-term care?
Yes, all of that is covered.
Gene, go ahead.
What do you think are the good parts of the United States medical system compared to Germany and vice versa? What's good about the German care that we should adopt in our country? As you know, we spend approximately $3.5 trillion on healthcare in the U.S. That represents the 5th largest economy in the world. It's very close to the GNP of Germany, and about a third of that is wasted. Do you have any ideas how we can start thinking in the next few years how to change that and create a more economical system?
Well, that's a difficult question to answer because it has a lot of different, aspects or thoughts to it. But let me start with the positive. So I think the good things in the U.S. healthcare system is that we have cutting edge in regards to research and technology. There is more technology involved, I believe, than in Germany. So in Germany, there's still a lot more relying on physical exam and taking a medical history. One of the problems, I think, is that the cost for services in the U.S. is just too high and hard to impossible to predict really what certain services will cost or what certain medications will cost. And it is very confusing because there are so many different systems, and depending on where you get a service performed or where you get your medications, there can be a huge range of costs, and that is very confusing for patients, and it's impossible to navigate. The other big thing that I think is a big difference is the way that how the system and the individual people and patients value the importance for preventative health care. So I believe that in Germany, people spend a lot more focusing on staying healthy without having to see a doctor. So they like to, they walk a lot more. They bike to work. There's not as much fast food available. And so that shows us that there's some systemic things that are in the U.S. that are harder for people, I believe, to stay healthy. So, for example, fast food is cheaper and more easily available than healthy food. The free soda refills, I know those are little things, but they do add up. And so I think a lot of the problems that cost a lot of money in the U.S. healthcare system are from chronic conditions that could potentially be prevented.
I would agree with you that the best thing we do in this country is that we have a process of researching, developing everything from a new procedure to a technique to a device to a chemotherapy agent, and I'm hopeful that we will do this as a program in the future. Let me kind of again take us in a little different direction. We talked about Medicare earlier. The United States Congress, in its wisdom, I think in 2003, 2004, I can't remember exactly the date, when they, quote, modernized, unquote, Medicare and established something called Part D, they passed this law that literally prevented the Medicare, which is the largest purchaser of drugs in the world, from negotiating with the drug companies. Again, in the wisdom of Congress, they put these people called pharmacy benefit managers in charge of this. These are frequently people working in for-profit companies that were supposed to negotiate a better fee for the drugs, and in fact, what's happened in this country is the drug companies can do whatever they want. So, with that sort of rambling beginning, how does the German healthcare system work out the details of what drugs are available, how much they cost? If you have 2 or 3 drugs that all do the same thing, do they all need to be on the market? And how's that managed?
Sure. So first of all, there are no pharmacy benefit managers in Germany. That does not exist. The insurance providers are allowed to have certain discount agreements with certain drug companies. If the patient has a prescription for a certain agent, then the pharmacy is obligated to offer one of the 4 cheapest products. The composition and the ingredients of these products prescribed and the replaced drug covered by the insurance has to be exactly identical. So it's a little different from here, where the FDA allows plus minus 20%, I believe, of the ingredient in the generics. And then the costs for the prescription drugs are the same at every pharmacy. So you do not, as a patient, have to go to a specific pharmacy system to get that cheaper drug. It's the same regardless of which pharmacy you cover. There's usually no mail order services. The prescriptions the length for the prescription is given at the discretion of the physician. And so usually physicians would write for about a 6-month supply or for a 1-year supply. And the patient can actually fill that entire supply at the pharmacy at a one-time visit. So they do not have to come back every month to get a refill, which can increase the compliance. And then there's no drug advertising on TV. It is illegal for drug companies to advertise prescription drugs to people other than doctors or pharmacists. And so there's actually a pharmaceutical advertising law which states that. So that is quite different from the US. And like I said, when I first moved here and started watching TV, I was just flabbergasted at all the drug advertising commercials. That just does not exist in Germany.
Now, who oversees this? In Canada, the Ministry of Health has I don't know remember what the name is. They have a drug committee, and the drug committee reviews the various drugs that are coming into Canada. They determine their effectiveness, and they also determine some sort of reasonable cost. It costs 10 times more to get an equivalent dose of insulin in this country compared to Canada. So is there a regulatory body who's overseeing all this and supervising it, or is this? I'm not exactly sure how that works in Germany.
Well, the German health ministry is involved in that, and there are laws that I believe most of the pharmaceuticals in Germany are actually still made in Germany, and so there's no problem or they're made by a German pharmaceutical company, and so there's no the problem that importing drugs from other countries is not as big of a problem as it is here. It's just, if you get a generic, it is somewhat cheaper than the brand name, but it is not 10 times as cheap.
Let me just say you're listening to Single Payer Radio here on WFMP 106.5 with retired surgeons and emeritus professors Dr. Michael Flynn and Eugene Shively. And today our guest is Dr. Miriam Krause. We're discussing the German healthcare model.
What if a new drug comes out that's very expensive? Let's say it's a monoclonal antibody, and it's for some unusual disease, and the drug company is having trouble putting a cost on that drug. In America, we pay for half of the entire drug cost in the entire world. How does the German system decide how much we pay for that drug and how long they're going to pay for it?
I don't know the exact details of the process, but I know that there are no such things where a new drug costs $100,000. That just does not exist. So I believe that there are regulations in place that say how expensive that drug can be. And once a drug has been on the market for a certain time frame, then generics can be made of it. So you cannot have a generic available of the same drug right away. There's like a patent on the drug. I don't know if that goes along with your question right now, but so as long as that patent is established, it's only the company that developed it that can market it and make a produce it. And then after that time frame is over, then the generics can be added.
If I was a German citizen and went out of the country, I'm going to tell a bit of a story here, but then get you going where you need to go. And the question is whether your healthcare travels. We were out in Colorado a year or two ago, and after dinner we went to a little bar where a couple of young men were playing guitars and howling at the moon. And I sat next to a man at the end of the bar, and he turned out to be a Swiss citizen. And we got to talking about some of these things, and he pulled his wallet out and showed me a card. He was he was a Swiss mountain biker, and explained to me that if he had some kind of accident, riding his mountain bike down the side of Mount Crested Butte, which I think is a form of insanity for somebody that old, he could actually be flown back to Switzerland to get care. Now, I don't know about Gene, but every time I go out of the country, it costs me $300 or $400 to get health insurance that will allow me to get evacuated from Ecuador or wherever I happen to be back to this country, so I don't have to stay wherever I am and get Medicare. So how does this work in the German healthcare system?
Yes. So I guess there's two different scenarios. The first one, if you traveled within the European Union, most healthcare insurances do cover any medical costs that would need to be applied if you were traveling within the European Union. Certainly, each state each country in the European Union has kind of its own preset, I guess, treatments that are done or provided in that country, and so there are some specifics within each country. But overall, that travel is usually covered, and you do not need any additional healthcare insurance, mainly because a lot of people travel all over work all over the European Union. If you travel outside of the European Union, let's say a German citizen comes to the U.S., then they would usually get travel insurance, and that is a lot more affordable than in the U.S. Basically, a person can choose to have a travel insurance for a specific time period, like the 2 weeks that they are traveling. They can pay for 6 trips a year, each trip being less than about 30 days long, or you can pay for travel coverage for an entire year. So there's a lot of different options. And this travel insurance is usually very affordable. The cost does increase with age and depending on where you go, and also what activities you plan on doing. So the guy that you met at the bar, the mountain biking, may have to pay slightly more just because of the activity that he's doing than somebody who just goes and lies on the beach. If you do bungee jumping, if you do diving, those are things that would increase the cost. But overall, again, the travel insurance is very affordable, and it is really only used for emergencies. And most Germans, as long as nothing crazily unexpected happens, will not have to use it. But it does allow, air back to Germany and things like that.
How does the German system decide which brand new technology becomes available and how do they use it? For example, robotic surgery, which is becoming very popular in the U.S. We have general surgeons who are doing cholecystectomies with a robot and fixing inguinal hernias with a robot. We have 3D mammograms, which are questionably better than regular mammograms, but it is being pushed predominantly by marketing, by the people who make these devices. How does that system work in Germany, and how do they decide who uses it and whether it can be used or not?
So there have to be studies that compare the new technology, the standard technology, and then the medical societies, let's say the German Surgical Medical Society, will give their input in whether they believe that this is a better option for treatment or diagnostics than the standard option. If people agree on that, then the basic healthcare insurance will then say, yes, we do cover the service. If they believe that it's not any superior to the standard treatment, then it will not be covered. So that's where, for example, if you do have the additional private insurance, they may be more likely to pay that newer technology than the basic healthcare insurance companies.
Go ahead.
Let's talk a little bit about how research or development is managed in Germany. In this country, if let's say there's an operation, a new operation that was developed, which being investigated, in which if you have a cancer of the pancreas, the surgeon places electrodes around the tumor, turns on the juice, and it creates an electrical field that destroys the tumor. I mean, this is the idea. So in order to have this investigated, it goes through a process where they do a few of these, maybe on mice or rabbits or some other situation. And then they do a small study, a pilot study with 15 or 20 humans who've agreed to have this done. And having identified that this may be of some benefit, then this study is expanded, and it falls into what's called a phase 1 study, where they use a larger number of patients. They have very strict protocols about how it's done, how the information is collected, and assuming they identify that there's some benefit in doing this, then they move on to what's called a phase 2 study, where they further investigate the effectiveness as well as to determine what the risks might be. So this is another step, and again, looking at larger numbers of patients, and this can be a study that's carried out in multiple institutions, and each institution may do 3 or 4 patients, and it all goes into some central database. And then assuming that this idea gets past the safety and effectiveness, then it goes into some phase 3 study where it can be compared with other treatments or compared with some other some way of evaluating it. These activities are overseen by institutions called institutional review boards. These are groups of people who usually work at universities, but they may be independent. And so every study that comes through the University of Louisville, whether it's a phase 1, 2, or 3, is initially reviewed and then followed closely by these institutional review boards. What kind of a process exists in Germany to allow somebody to come up with an idea for an operation, or a drug company to come up with what they think is going to be a new drug, a monoclonal antibody that may be effective against a specific type of cancer, and put it through the process of determining, 1, whether it's effective, and 2, whether it's safe?
So I believe that system, or the different steps that you just mentioned, those are very similar in Germany as well. So we have IRBs, we have the German Research Foundation that is a nationwide surveillance agency, and usually trials are performed at the university hospitals, teaching institutions, where all the research is done. We have the different phases of research. I believe that the input of like drug companies sponsoring it is less than what it is here. So it's very objective, and it has to go through a lot of different reviews to make sure that the new treatment is better, or at least as good as the current one. That's all the details I'm aware of at this point.
Let me ask you, are most Germans happy with their healthcare system?
I would say overall they are happy. I mean, the German system is not perfect. We are seeing some trends that we're seeing in the US as well, that insurances are starting to decrease coverage of some services, but not at the same magnitude as in the US. And again, nobody will have to fear bankruptcy. They will get the basic treatment in case of a medical emergency, and I think that's a good reason to be happy with it.
What about hospice and palliative care? We were way behind on hospice and palliative care for many years, but we've now become better at it, and it's much more popular. Do the Germans use palliative care and hospice care in patients who we don't think they can cure, and is that becoming popular?
That is definitively being used, and it is, I think, becoming more common just because the age of the population is increasing. I'm not 100% sure on how the coverage is. I believe that after a certain amount of time, definitively there will be co-pays. There are co-pays, or the family has to chime in, but it is, again, not in the same magnitude as it is in the U.S.
Just to drop back again to the the IRB issue, I've been on the University of Louisville IRB for probably 15 years, and one of the patterns that I've noticed is initially, as a member of the IRB, a good proportion of the protocols that we reviewed were from research bodies, the Children's Oncology Group, or the RTOG, the Radiation Therapy Oncology Group. And now I've noticed that we are seeing fewer studies and protocols submitted by independent study groups, and more of these studies are submitted by drug companies. So the balance of research in this country seems to be shifting away from independent study groups to companies that are looking for ways to make more money. So again, my question related to that was, have you seen what sort of trends are going on in Germany, or are you aware of that? Since I guess you've been away for a long time.
Yeah, I'm not quite sure on how these things are done currently. My thought is that since, drug advertisement is not allowed, that would be very much decreased, if at all it was allowed. It may not be allowed at all, but like you said, that may have changed some since I've left Germany.
I have a question. If you were commissioned to write a white paper on how to improve American medicine, particularly from an economic standpoint, what would be some of your top items?
I think my top item would be preventing chronic diseases by changing lifestyle, changing the lifestyle, making having people try to have a better, healthier lifestyle. That's, I think, the biggest one, because I believe that it affects so many different aspects of medicine. The other part is just the the complexity of navigating the cost of the drugs and the services provided if the different insurance companies in network, out of network, certain pharmacies that only can be used. The third one is that ER institutions, emergency rooms per se, do not exist in Germany. There are ERs available if people have a true emergency, but there's no ER residency. There's no ER specialty training. And so if people have a true emergency, they would go to the hospital. If it's a surgical emergency, they go to the surgery hospital, and they get treated there by the staff that is on call in the hospital. But ERs do not exist like they exist here. And so people use a lot more primary care for visits that would be seen here in the ERs. There's a lot more better access to primary care. I think in Germany, there's a higher density of primary care physicians to make up for those ER visits. So I believe those are kind of the big things that I would focus on.
And now in Germany, the continuity of care is done primarily through the primary care physician.
Correct. And if your insurance changes, then you would still be able to see the same primary care physician, because most of the primary care physicians are contracted with all the basic healthcare companies, health insurance companies that there are. So oftentimes here, I see that people change insurances and then they have to go see a different primary care physician and start all over again. And in Germany, you stay with your primary care physician the entire time unless you move away.
And your primary care physician would know what's wrong with you. He would know all your other medical illnesses. He might even know you personally. And so
correct.
Now, if it's in the middle of the night and you start having abdominal pain, let's say it's 10 o'clock at night, and you've been at the Hofbrauhaus and you're having pain, would you call your primary care physician, or would you go to the ER?
So first of all, I think if the pain was not terrible, then people would try to just manage it at home. They would maybe take some Tylenol, they would rest, they would see what happens and try to call their doctor in the morning. If it was a, unbearable pain and they're really worried, then they would either call their primary care doctor, and the primary care doctor would answer the phone. Or again, if it is a true emergency, they would go to the hospital that's closest and then be seen by the surgical resident or attending who's in hospital in house there.
Doctors, I hate to end this, but another hour or a little less has flown by. Dr. Krause, thank you so much for giving us German healthcare system 101 primer here. It's very helpful.
Well, thank you, Paul.
Your answers were very, very, very concise and very helpful. Thank you.
Thank you all for having me.
We really appreciate you coming.
Okay, guys. Thanks again for listening to Single Payer Radio. Want to let you know that Single Payer Radio is going back to a weekly format. We can be heard at Monday at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. That weekly format, by the time you hear this, will have already started. For more information about Kentuckians for Single Healthcare, you can go to Single Payer Healthcare. You can go to kyhealthcare.org. Doctors, thanks again for coming in. Another great show. Dr. Krause, thanks again.
Thank you.
Thank you all. Have a wonderful day. Bye.
Bye.